Right, we have a total knee replacement, abbreviated as TKR or TKA, which is a total knee arthroplasty. It's a highly successful procedure, and it's aimed at relieving pain and improving function for those with severe arthritis of the knee joint and of those who lose articular cartilage in the affected joint. What they actually do, the intricacies and the risks involved with the surgery far outweigh the disability and the possibility of you spending the rest of your life in pain and in agony and not being able to function as a human being and being mobile to get around. Okay, so to understand a better understanding of that total knee replacement, we need to go into the anatomy of the knee. And this is a tibiofemoral joint, and it's said to be the most complex joint in the human body, and it's also the largest. It consists of, on top you have the femur, of course you have the tibia, you have the fibula, which isn't really part of the articulation, but it does stabilize the joint capsule, which is done by the two ligaments that we have here. We have the lateral collateral ligament and the medial collateral ligament. We also have the quadriceps, which are attached to the patella, which also articulates with the head of the femur there. We then, the two ligaments here on the outside, as I said, support the joint capsule, and the two on the inside would be the anterior cruciate ligament and the posterior cruciate ligament. They're both named for their insertion on the tibia. And of course, the two of them prevent anterior and posterior translation of the tibia on the femur. And in my research, I thought it was quite interesting that these two ligaments are considered to be intracapsular but extrasynovial. So they're not included in the synovial joint, which is within the capsular joint. The synovial membrane actually wraps around them, which excludes them from the synovial fluid therein. Within the synovial joint, you'll find the two menisci, the lateral and the medial meniscus, and they rest on top of the tibial plateau, which has a certain amount of articular cartilage on that. The menisci and the cartilages of the knee are nourished by the synovial fluid. So it's important to remember that the cartilage is avascular, and its only way of getting nutrition and waste removal and respiration really is from the synovial fluid. And interestingly enough, a sedentary lifestyle will inhibit the nutrition getting to these cartilages and the menisci, purely because when you start warming up and the synovial fluid heats up, it becomes thinner and is then absorbed by the cartilages, which then of course make them puff up a little, which is better for articulation. And then with you compressing your knee or using your joint, the cartilage absorbing it and releasing it on that keeps your cartilage healthy and in good shape. So the next vital component, as I mentioned earlier, is the patella. And the quadriceps tendon pulls the patella superiorly, and then it's also connected here to the tibia by the patella ligament, and that then pulls it inferiorly. The various portions are highlighted there that we've been through. And then of course an interesting thing too is that the articular surface of the patella is the thickest in the body. And in biology we learned that form follows function. And the reason for that is the tremendous amount of compression forces that play on the patella. So in the diagram here, regular walking places a compression force on the surface of the patella about 1/3 of your body weight. If you're climbing upstairs, it's 2.5 times your body weight on that small little sesamoid bone, the patella. If you're descending stairs, it's 3.5 times your body weight, which is compressed on there. And of course, if you're in a deep squat, it's 7 times your body weight. So that explains why it is that thick. As far as etiology and incidence of a total knee replacement, the main indication for the surgery is osteoarthritis, and it accounts for 94 to 97% of all total knee replacements done. As we heard and as we know, osteoarthritis is a general wear and tear disease, and you can see in the pictures here a healthy knee opposed to an osteoarthritic knee, where the wear and tear eventually through the cartilage starts wearing away on the bone. If you have bone rubbing on bone, the body then defends itself by producing more bone, then you have bone spurs, and then the bone spurs are irregular shaped and they then cause further damage. Okay, so there's no cure for osteoarthritis either, and the last treatment for this, of course, is a total knee replacement where you'll cut all those surfaces off and replace them. A total knee replacement costs about $15,000, and it's estimated that last year there were about 600,000 of them done in the US alone. With aging populations increasing in developed countries, as well as the rates of obesity increasing at the same time, it's no surprise that there's going to be a huge increase in joint replacement surgeries. For knee replacements specifically, the burden on the medical care program was $9 billion last year, which is a ton of money. There's one more thing actually. There was a study presented at the American Academy of Orthopedic Surgeons that strongly advocate the double bilateral knee procedure being done at the same time. The reason for it, they say, is it significantly reduced the rates of revision as well as the mechanical malfunctions of the joints themselves. Now, the study included 11,445 people who had them both done at the same time, and then it was compared with a little over 23,000 patients that had them done probably about 5 to 6 months apart. It kind of makes sense that if you have both knees done at the same time, it's going to cost you less money, first of all, and the amount of damage that you're likely to do to the knee. If you have one damaged knee and you're walking around with one good knee, you might not be cognizant of it and turn around too fast and damage the other one. Whereas if you have both damaged, the outcome is generally a little safer. There are some non-surgical options, as surgery is the final straw. It's the very last thing. They try and prolong it as long as they can and avoid you actually having the surgery. A few lifestyle modifications are, first and foremost, is weight loss, which is a major factor. If you have arthritis in your knees, the heavier you are, the more pressure you're placing on the joints. Of course, exercise and physical therapy improve core strength and flexibility, and aquatic therapy, which is in a pool, is an effective treatment for arthritis because the water offers mild resistance while removing weight-bearing stresses, which will be placed on the joint. We also have braces. Braces can be used, and they help carry some of the burden, some of the weight that you ordinarily would carry yourself. And of course, also postural corrections need to be made. As you've seen the picture above there, standing up straight, you've got 12 pounds of pressure going down, and that gradually goes up as your posture goes down. There's also some injections that you can go through. There's one called COX-2 inhibitors, which directly target the enzymes responsible for inflammation. And also corticosteroids, as I'm sure we've all heard. That's a powerful anti-inflammatory agent, and it's injected directly into the synovial sac, or the synovial space. There's also another treatment called vascosupplementation, which involves injecting non-cortisone or naturally occurring substances because it's a little safer with less side effects. The indication for surgery. Now, the success of knee replacements is largely determined by the selection of the patients that actually go for knee. Not anyone can just go for it. The prosthesis, first of all, has to be individually tailored for that specific person. In the same respect, the person needs to actually match and be a candidate for the surgery. So there's 4 main criteria for choosing or for qualifying for a knee replacement, and that's the disease that you're currently suffering from, the symptoms or the severity of it, and any past surgery that you may have had may impact the possibility of the surgery not even being effective for you. And of course also your medical and fitness levels need to be assessed. If you're 400 pounds they're not going to look at you for a knee replacement surgery until you lose some weight. We also see that people under the age of 55 are also less likely to get candidacy for this. Of course, you've got enough money and you're persistent enough, you can have it done, but surgeons ideally want to have you a little older purely because the prostheses aren't designed to last that long and revisions are really risky. We have a total knee replacement, which is the gold standard for this, but we also have partial knee replacements, where one of the three components, either lateral, medial, or the actual patellar surface individually will receive a prosthesis alone. As far as the surgery goes, it's pretty involved, it's pretty complex. It normally takes about 1 to 2 hours. The patient is given antibiotics and wrapped entirely in a sterile sheet. All the surgeons and the medical assistants are also fully encased in a medical spacesuit almost, with an oxygenated helmet to keep that unit, because it's a single unit cut off to limit the bacteria or any sort of infection which could have serious detrimental effects on the surgery. The operating room itself, they use a laminar flow system where they're constantly pumping out clean, filtrated antibacterial air, moving it away the whole time. It's either on the back of the wall and it's constantly flowing away from the patient, because everything's cut open and wide open, or it's coming from the roof and being recirculated in that way. The surgery itself, they start off with about an 8-inch incision over the front of the knee. They'll go through the skin, and once they get to the quadriceps muscle and the tendon, they'll have to slice that to split that apart as well. And that's pretty much why the surgery and the post-surgery is so much more painful than a hip surgery, because they actually cut into muscles and tendons. A big caution is the actual lateral and medial collateral ligaments. They're vital to a successful recovery because they stabilize the whole joint. So they are pushed to the side and got steel braces around them so that they can't be damaged in any way. As far as the other ligaments go, they all removed. So you've got the menisci, they'll be removed, the ACL and the PCL will be taken out of there as well. Once that's all removed, they'll put in the cutting guides, which you can see on the picture over here. And those will then guide the surgeons and the electric saw to cut the bone to perfectly fit the prosthesis that's going on it. That's then cleaned up, and they then use a medical cement, which they'll then place on the clean bone and the prosthesis and then stick it in place. Once it's sticked in place, they'll go through the range of motion with the patient. And the femoral head is usually made of polished cobalt chrome. The tibial plateau is normally made of stainless steel or titanium. Stainless steel, I think, is up in the past. And then, of course, the portion over here, which now represents the meniscus, that is made of a high-density polyethylene component. Okay. So once range of motion is checked, it's then all stitched up, and then the patient is taken to another room where they can check his vital signs and vital organs from a traumatic invasive surgery of this nature. And then in his room, that'll also be checked, and he'll remain in the hospital for 3 to 4 days. While he's in the hospital, he'll be on anticoagulant medication and analgesics to rest and heal. And depending on what time the surgery was done in the day, physical therapy will start the same day, or it will start the next day, early the next morning, that is. There's a couple of the components, as mentioned earlier, and how they all fit together. It's quite interesting how they replace the entire inner surface of the patella. So we saw how much weight that actually bears. There's something called a CPM, a continuous passive motion machine, where literally the day after surgery, the affected leg will be hooked up to this machine. This will passively, without any effort from the patient, move him through various degrees and ranges of motion to keep it moving, because an excessive buildup of scar tissue will inhibit movement later on. And then also aquatic therapy, that can only be done once the incision is actually healed. Okay. Another important aspect of the surgery is the fact that the ACL and the PCL, as well as the meniscus, are removed. But the ACL and the PCL are, as I mentioned earlier, they're not part of the synovial capsule, so they actually are innervated, and about 3 to 4% of them is proprioceptive afferent messaging going back to the brain, so the brain knows where the knee is in relation to its extension or flexion, and in its relation to space. So physical therapists need to do a lot of peripheral neuromuscular facilitative stretching to aid. I'm not quite sure, the research that I did, whether they can bring that proprioception back, or if this is just a coping mechanism to deal without it. Okay, so various techniques are done there. We then, the team involved, of course, there's a huge orthopedic surgeons and nurses and assistants involved there, and then also your family care. Because especially if you're having a double knee done, you literally, even one knee, you're not going to be able to drive, you won't be able to walk around. So they pretty much advise you to choose a person that you really trust, a family member, to be your coach, they call it, throughout this process, which will then take you to physical therapy, will help you get through the home exercise program, which is vital to your full rehabilitation. We then have pain management. The pain associated with knee replacements is all associated with the nerves that actually run through the knee. Obviously, cautions are taken not to sever those nerves during surgery, but sometimes they are. The knee is innervated by the femoral, the sciatic, and the obturator nerves. And the surgery itself is done under either epidural spinal anesthesia or general anesthesia. The amount of anesthetics given to the patient also need to be balanced with, if you have an epidural and the patient cannot feel anything from his waist down for the next 2 days, it's going to affect his physical therapy after that. He needs to be able to move his affected limb. So there's a very fine balance between how much to give, how to give, whether it's a local nerve block or whether it's an epidural. And after that's all done, the moderate to severe pain after surgery is, they say, oxycodone or oxycontin, which is pretty effective, but you also need to be aware that it's pretty addictive. It's got highly euphoric properties and can be abused quite easily. We then have the prognosis. The prognosis of the surgery is considered very good, and it is constantly improving. And there's the Swedish Knee Registry, which has a list of all the knee surgeries ever done in Sweden from 1975 to 2011. So based on that wide array of information, there was only a 4% risk of patients with osteoarthritis having knee replacements needing revisions after that. Okay, the longevity of the components in the knee, a multiple of factors depend on how long that lasts. If you're a younger patient, you're more active and you end up doing more wear and tear on it, it will deteriorate a lot sooner. Any high impact also dislodge it in the medullary canal. And the artificial components, they say, last about 15 years, depending on how well you use it. So if you're 50 years old, it means you've got to go back at 65. They'd rather have you have the surgery at 65 and take it from there. Okay. So thanks for listening, and